Hello everyone, can all of you hear me?
Yes.
Okay. Hello everyone, I'm Dr. Muaz. Welcome back from a long Eid holidays, right? So there was Eid holidays as well, and I was doing all of my packing and stuff as well, so I could not join yesterday due to that. I'm so sorry. Without that, we are gonna start today. Right? We're gonna start today. And the next topic the topic that we left was what is renal blood flow regulation, right? So now we are gonna start from first of all filtration, right? First of all, we are gonna start filtration, right? We have discussed filtration in detail already, right? So what was filtration? So filtration basically meant that the blood that was coming at the nephron, right? So if this was the nephron, so we are doing nephron physiology, right? If this was the nephron, right? And if blood was coming at this nephron, right? Then how much of this blood got filtered here, right? How much of this blood was coming into this nephron was known as filtration, right? And we call it as a filtration fraction, right? That is known as the filtration fraction. So normally filtration fraction is 20%, right? Basically, that is known as the filtration fraction. So GFR is the filtration. The glomerular filtration rate tells us how much blood is going to come in 1 minute. That is known as the GFR. And how do we calculate the filtration fraction? We take the GFR, right? We take the GFR and we divide it by the renal plasma flow, right? Now we'll go into details of renal plasma flow soon, right? And the normal filtration fraction. So in filtration fractions, which how much percent of the renal plasma flow that is coming into the nephron is being converted, right? Is being converted. That is known as the filtration fraction, right? This thing is the filtration fraction. Now, how can we estimate the GFR? We can estimate the GFR with the help of creatinine clearance, right? We have already discussed creatinine clearance, right? No, we have already discussed the other thing as well, right? What is that? That is, there are two arterioles. One arteriole is known as the efferent arteriole, right? And the other one is known as the efferent arteriole, right? And if we dilate the efferent arteriole, the GFR is gonna increase, right? It increases the GFR, and right, and so basically, whenever you dilate it, GFR, okay, so the GFR is going to increase, right? At the same time, if you constrict the efferent arteriole, right, the GFR is going to decrease, right? The GFR is going to decrease. So if you constrict the efferent arteriole, right, the GFR, okay, we'll go into the detail of efferent arteriole later, right? Because that is complex. It has a dual mechanism, right? So first of all, if you dilate the efferent arteriole, the GFR is going to increase. This is important. Now, what are the things that dilate the efferent arteriole? So prostaglandins are going to dilate the efferent arteriole, right? Prostaglandins are going to dilate the afferent arterioles. Okay. So when prostaglandins dilate the afferent arteriole, what is going to happen is that the GFR is going to increase, right? So that is why prostaglandins are very important in maintaining the kidney blood flow and the kidney function, right? Again, prostaglandin dilates the DFR. This is important because this comes into play whenever you are having any condition in which we take a lot of NSAIDs, right? Whenever we take a condition which in which we take a lot of amino acids, that is gonna increase the GFR. That is gonna decrease the GFR because NSAIDs block the production of prostaglandins, right? NSAIDs are gonna block the production of prostaglandins, so the production of prostaglandins are gonna get blocked first of all the direction so the prostaglandins won't be formed, and when the prostaglandins won't be formed, the GFR is going to be reduced. So that is why NSAIDs, how NSAIDs are going to work, right? This is the first clinical bit. This is the first clinical point that can come in your exam, that can come in the U world, right? Second thing is that whenever you constrict the efferent arteriole, the GFR is going to increase again, right? Whenever you constrict the efferent arteriole, the GFR is going to increase again. Now, what things constricts the efferent arteriole? The thing that constricts the efferent arteriole is angiotensin, right? So if you take, again, if you take the if we give the patient angiotensin receptor blockers, ARBs, or angiotensin converting enzymes blockers, right, such as ACEs, right, then again, what is going to happen is that the GFR is going to decrease, right? Now again, the GFR is going to decrease, and when the GFR decreases, right, again you are going to have problems, right? The creatinine is going to increase, right? The creatinine is going to increase. So keep this in mind, guys, right? This is important. So, okay, so any questions till now for this thing? Okay, so that was efferent arterial construction, and then when there was efferent arterial construction, right? So keep these two in mind, right? Keep these two ones in mind, right? With that, let's move on to a very important topic, which is the glucose clearance, right? So glucose clearance basically means how is the glucose gonna get cleared from the body, right? How is the glucose gonna get cleared from the body with the help of kidneys? This is important because whenever we are having diabetes, there will be problems regarding glucose intolerance, right? Then we have to understand the concept of splay, filtration, excretion, and reabsorption, right? So first of all, the normal glucose concentration is 60 to 120 milligram per deciliter, right? The normal glucose concentration is 60 to 120 milligrams per deciliter. Now, when the concentration is this much, then we already know. Okay, so can someone tell me if the concentration is this much, almost all of the glucose is gonna get absorbed, and what structure absorbs the glucose? Right? What is gonna absorb the glucose in the nephron?
Sodium
And where
glucose
is
post transport.
SGLT2.
yes, yes, and where is it gonna get absorbed? At what part?
Proximal convoluted tube.
Proximal
Yes, so it's
convoluted.
yeah, so SGLT2 at the proximal convoluted tubule is gonna absorb all of the glucose, right? Now, SGLT2 has a limit, right? And what is the limit? The limit is 200 milligrams per deciliter, right? We have a limit, and the limit is 200 milligrams per deciliter. Once you reach the limit of 200 milligrams per deciliter, what is gonna happen is that the glucose is going to appear in the urine. Why? Because it's not going to absorb all of the urine, right? All of the urine is not going to get absorbed. All of the glucose is not going to get absorbed, and then glucose is going to come into the urine, right? So 200 milligram per deciliter is an important thing. Now, this thing is known as glucosuria, and it's a very important indicator of diabetes, right? This is known as the diabetes, right? Now, whenever you are having pregnancy, right? First of all, let's look at the pregnancy. Whenever you are having pregnancy, GFR increases. Okay. So now we have to look at another concept. Let me tell you that. So we have something known as the albumin and the plasma proteins, right? We have the plasma proteins, right? Now, we have a thing which is known as the plasma proteins. And the main plasma protein is the albumin. So keep this in mind. We have a lot of plasma proteins, and the main plasma proteins are the albumin, right? And we look at and if we look at the GFR's formula, we are gonna see one thing, right? Now, if we go again back into the GFR formula, we are gonna see one thing. If this is the GFR, right? So GFR depends on two things, right? First thing is the pressure in the glomerular capillaries, right? And the second thing is the pressure in the hydrostatic space, right? This is the first thing. The second thing is that the greater is this thing, the greater is the first thing, the greater is going to be the GFR. Now, second thing here is the oncotic pressure. So, what is oncotic pressure? Right? What is oncotic pressure? So, this is in minus, right? So, the greater is the oncotic pressure, the lesser is going to be the GFR. The oncotic pressure is the pressure that retains fluid in the blood vessels and do not let it leave into other structures. Again, oncotic pressure is that pressure. So you're going to see oncotic pressure in a lot of places, right? So oncotic pressure is that pressure. So if this is a blood vessel, right, and if there are substances here, normally substances are gonna go out of the blood vessel wherever you go. They are gonna go into the heart. They are gonna go into the structure of the heart. They are going to the structure of the muscle, right? So all the substances are gonna leave, right? This thing is known as filtration, right? And all of the things are gonna go out. Right. Similarly, whenever you will be going into the into the nephron, a lot of things are gonna go out. A lot of things are gonna go on. And when you're gonna see this, you are gonna notice that the greater is the oncotic pressure. So if the oncotic pressure is increased and the oncotic pressure is maintained by albumin, right? So if these are albumin molecules, and that is gonna maintain the oncotic pressure. The greater that will be the oncotic pressure, the lesser the substances are gonna be are gonna be filtered, right? Albumin is gonna hold all of these substances in the blood, and it's not gonna let all of these substances go out and to be filtered, right? So now my question is, if a person is having increased amounts of albumin, what will be happening to the glomerular? What will be happening to the GFR, guys?
Will
Reduce.
decrease.
Yes, so GFR is going to be decreasing when the plasma proteins are going to be increasing, right? So when the plasma proteins increase, the GFR is going to decrease, right? When the plasma protein increase, the GFR decreases, right? Though you have to look at this thing, which is whenever we are having pregnancy, right? Whenever we are having pregnancy, right? Will the plasma protein levels increase or decrease? Because during pregnancy, the blood is going to be diluted, right? So basically, we measure anything by the dilution or concentration, right? So now, since the blood is going to be diluted in pregnancy, we are going to have very much increased amount of blood volume. What will happen to the plasma proteins level?
Decrease.
Yes,
Decrease.
so the plasma protein levels are going to decrease in pregnancy. And as soon as the plasma protein level decrease in the pregnancy, right? As soon as the decrease in the pregnancy, the GFR is going to increase very fast, right? That is why in pregnancy we have increased amounts of GFR. Keep this in mind. They are going to ask you, why is the GFR increased so much in the pregnancy, right? Why is the GFR increased so much in the pregnancy? GFR is increased so much in the pregnancy because the plasma proteins are gonna decrease, and that is gonna lead to decreased oncotic pressure, and that is gonna cause an increased GFR, right? So this is gonna favor filtration, and we are gonna have that thing, right? Now, similarly, now there are two clinical examples of this thing, right? The first thing is known as the nephrotic syndrome, right? What is nephrotic syndrome? Nephrotic syndrome is a syndrome in which the nephron is going to lose its barrier, and as a result, all of the proteins are going to get lost. Right. So the all of the proteins are going to get lost. Right. When the protein loss is going to be greater, right? What is going to happen is that the G, right? So if the proteins are getting lost, the proteins in the body are going to be low, right? The proteins in the body are going to be low, and the GFR again is going to increase. And when the GFR levels are going to increase, right? What is going to happen is that again you are going to get increased amount of filtration, and then increased more proteins are going to be lost. Right. So this is a very bad cycle, and this bad cycle is going to happen in case of nephrotic syndrome. Right. This is the first thing. The second thing is that the same thing is going to happen in uh, this is the first example. The same thing is going to happen in malnutrition as well, right? So they could give you different examples that a patient is suffering from malnutrition, a patient is suffering from nephrotic syndrome, or the patient is not eating enough protein, right? And what is happening to the patient, right? And they're going to ask you what is happening to this patient, right? What's wrong with the patient, right? And you have to look at these parameters, and then you're going to have to check. Similarly, if you are having dehydration, right? Whenever you are gonna dehydrate, right, the protein levels are gonna increase. How? Because the proteins are gonna get concentrated. Now, when the protein levels increase, the GFR is gonna decrease, right? Why is this important? This is a good mechanism by our body because once the GFR is gonna decrease, there is going to be less urine formation, right? And all of the urine is going to get almost all of the blood is going to get cleared, right? Yes, Dr. Laiba.
Sir, the task that was given to us yesterday, there was a question in it, and it mentioned the constriction of ureter. Um, in the first stage, it says that constriction of ureter will decrease your GFR, but it will have no effect on the renal plasma flow. Can you please
Yeah,
elaborate on that,
yeah. So we'll go over it too, right? So we'll go over it too. So, but did you guys first get the dehydration part?
Gigi?
Yes. Okay. Okay. So now we are gonna move on to the construction of ureter. Right. Let's move on to the construction of ureter. Right. So what is gonna happen in the uretary construction, right? So for that, let me make up a diagram. Right. So if this is the kidney, right? If this is the kidney, this is the kidney, and this is the ureter. Right? This is the kidney, and this is the ureter. Now, what is gonna happen is that whenever the urine is gonna back up here, right? As soon as the urine is gonna back up here, it's gonna go back into the tubules, right? It's gonna go back into the tubules, right? So if this is the Bowman's capsule, so if this is the Bowman's capsule, right? And ultimately this thing is connected to the ureter, right? So it's gonna go here and it's gonna get connected to the ureter. It's gonna go here and it's gonna get connected to the ureter, right? Now here there is gonna be a ureter and all of this thing is gonna go back and thing is gonna go here in the Bowman's capsule as well. So the Bowman's capsule is gonna have increased amount of water pressure as well. And from here there is gonna come blood here, right? The blood is gonna come here, right? So basically there are three forces uh, that are needed for filtration that are acting in favor or against. The first is the pressure inside the blood, because the pressure inside the blood is gonna force all, so the pressure inside the blood which is present here is gonna cause all of the blood to go out and to be filtered. So greater is the pressure in the blood, the greater is gonna be the filtration, right? This is the first thing, the pressure in the blood. The greater will be the pressure in the blood, the greater is gonna be the filtration, right? So the first force is pressure in the blood. So whenever we are seeing a front physiology, we have to look at these three things. The first thing is pressure in the blood. The second thing is the oncotic pressure, right? So how many proteins are present? We have already done with that thing. The third thing is the pressure in the Bowman space, right? The third thing is the pressures in the Bowman space. So the pressure that you are seeing here, the pressure you are seeing in the Bowman space, what is that pressure gonna do? That pressure is gonna oppose this thing, right? That pressure is gonna oppose this thing. Right? This pressure is gonna say that please. So the body knows that we already have a lot of filtrate that is present here. The the pressure in the Bowman space is gonna say we already have a lot of filtrate, and this a lot of filtrate is already present in the Bowman's capsule. We do not need any more filtrate, right? We do not need any more filtrate in the tubules. The tubules are already overloaded and the ureter is not working properly. So keep your filtrate to yourself. And as a result of that, the GFR is going to decrease then, right? As a result of that, the GFR is going to decrease. Okay. The GFR is going to decrease. So, any questions? Did you get it?
You go with one more time, please.
Okay. Okay, sure.
Sir? Yeah, the GFR part is clear. I was confused with the renal plasma flow.
Okay, so the renal plasma flow is not going to change, right? It's not going to change in case of constriction of ureter. It's going to stay the same. Whenever in case of plasma protein concentration, right, and in case of constriction of ureter, the renal plasma flow is going to stay the same. It's not going to change in case of constriction of ureter because the constriction of ureter won't do anything with the renal plasma flow, right? It's going to stay the same. Now, Uh, let's go over it once again, right? So whenever we are looking at the glomerular filtration rate, there are three things that are gonna act in the favor or against. So two things are gonna act. So first of all, the first thing is the blood pressure, right? So the pressure inside the glomerulus. So the greater is the pressure inside the glomerulus, inside the glomerular capillaries, the greater is going to be the GFR, right? So if I increase the pressure here, the GFR is going to increase, right? The second thing is oncotic pressure, right? So oncotic pressure means the pressure that is exerted by the albumin. The greater is the oncotic pressure, the lower will be the GFR. So if more proteins are present in the blood, if more albumin are present in the blood, the lesser is going to be the GFR, right? The third thing is that pressures in the Bowman space. So this thing is known as the Bowman space. So greater, so if there is lots of pressure here, so for example, if ureter is blocked here, if we block the ureter here, what is going to happen is that a lot of things are going to get accumulated here, and a lot of these things are going to oppose the filtration. It's going to say that we do not need any more filtration, and when that is going to happen, you are going to get reduced amount of GFR, right? But that won't affect it won't directly affect what do you say the renal plasma flow, right? It won't directly affect the renal plasma flow, right? Okay, now let's go to the other question, other thing.
So I'm not clear with this renal plasma flow part, but in the end, if we have some spare time, can you explain it a little more?
Okay, I'll go it in the I will go into its thing again, right? Okay, don't worry. Okay. Now, one more thing that I had to tell you guys was loop diuretics, right? So if you look at furosemide, right? If you look at furosemide, I think we're gonna. So remember one thing regarding furosemide. Furosemide is a drug that is gonna cause sodium loss in the urine, right? It's gonna decrease sodium. So it's just gonna cause sodium loss in the urine. So keep this thing in mind, right? So furosemide is gonna cause sodium loss in the urine, right? And second thing is that we have another thing which is known as the NSAIDs, right? So we have already gone into the details of NSAIDs, but remember, what are the things that NSAIDs are going to do? First of all, NSAIDs are going to decrease the prostaglandins, right? This is important. I am telling you again and again. Viewers are going to give you a question. They are going to say that a 40 or 50-year-old male comes to you. The patient is having the patient was having pain for the past 30 or 40 years, right? Or the pain was having pain for the past 20 years, right? He was taking ibuprofen for that pain, and now the patient is having swelling of legs and abdomen, right? The patient is having swelling of legs and abdomen, right? The patient is having nausea, the patient is having vomiting, the patient is having pedal edema, the patient is having ascites. All of these are symptoms of chronic kidney disease, right? So the patient is now having chronic kidney disease, and then they would ask you what would be the levels of prostaglandins, what would be the GFR, right? And what would be the urinary sodium excretion, right? And what would be the urinary sodium excretion? And then the first thing that you have to see is what would happen to the prostaglandins. So I've already told you that whenever we are giving patients NSAIDs, the level of prostaglandins are going to decrease, right? Whenever you are going to give the patient NSAIDs, the level of prostaglandins are going to decrease, right? And when the prostaglandins are going to decrease, the GFR is going to be decreased as well, right? And when you are decreasing the GFR, the sodium excretion is going to decrease as well, right? So keep this thing in mind. Okay. So now uh, we were at the pregnancy part, right? So whenever there is pregnancy, the GFR is going to increase, right? So when the GFR is going to increase in pregnancy, right? So a lot more of the blood is going to be filtered, right? So if normally at 200 milligrams per deciliter, the transporters, the SGLT2 was saturated, right? So first, if at 200 grams per deciliter, the SGLT2 was saturated. So since in pregnancy, the GFR is increased so much, it's the transporters are now going to get saturated at much lower concentrations, right? At 150 or 120, right? So they are going to get, so now they are going to get concentrated. So now they're gonna get saturated at 150 or 120. Why? Because even at 150 or 120 milligrams per deciliter, a lot of glucose is gonna get filtered due to the high GFR, right? So this is known as the filtered load, right? So what is the filtered load? So what is filtered load? So filtered load basically means that it means GFR into the plasma concentration, right? Normally the GFR is 120, right? And the plasma concentration of glucose is 120. That brings us to, if we calculate this filtered load of glucose, the normal filtered load of glucose is going to be 14,400. So 14,400 is the value at which glucosuria begins, right? This is almost the value at which glucosuria begins, right? Now, if we increase the filtered load, so how can we increase the filtered load? We can increase the GFR or we can increase the glucose levels. So in order to go above 14,400, we can increase the P, which is the level of glucose in the blood. So normally it is 120. If we increase it to 200, right? Then, so for example, let's make it 200. So if the GFR is 120 and we make the plasma concentration of glucose 200, what is going to happen is that we are going to get the glue filtered load 24,000. And the nephron is not going to be able to handle this amount of filtered load. Or one other thing can handle it, happen is that the the one the GF the plasma concentration remains the same, but the GFR now becomes 250, for example, and the plasma concentration remains same. Now again, what is going to happen is that glucosuria is going to occur, right? So they could ask you, how does glucosuria occurs in case of uh, pregnancy, right? Keep this thing in mind that how pregnancy is going to affect the glucosuria, right? Any questions still now? Okay. So now I think was this the question that you were asking me? Let me see. Okay, so Dr. Labo, was this the question that you were asking me? That was in the U world. Okay, guys, can you look at this?
Um,
Yes.
yeah, I'm not sure if it was this one, but it was a case of acute ureter obstruction.
Yes, so this
If
is a
I'm not.
case of acute ureter obstruction. Yes. So it is, I think this was the question. So, guys, first of all, can all of you read this question and tell me what do you think the diagnosis would be? Right? So if you see here, right, what is going to happen is that as I have already told you, right, that whenever the ureter is going to get constricted, right, whenever the ureter is going to get constricted, right, it's going to increase the pressure inside the tubules, right? The pressure inside the tubules is going to increase, right? Bowman space on cortic pressure. When is the Bowman space on cortic pressure going to increase, right? So first of all, let's start from the Bowman space on cortic pressure, right? So the Bowman space on cortic pressure is gonna uh, so the Bowman space on cortic pressure is usually negligible, right? We can just skip this thing. So the Bowman space on cortic pressure means that proteins that are present inside the Bowman space, right? So if this was the Bowman's, so let me draw the Bowman space once again. So if this was the Bowman space, right? And if these are the blood vessels, right? Then no proteins are present here. So
Cricket.
there is no Bowman space. What? So there
Come,
is no
cricket,
Bowman
come.
space here. So now, so now no Bowman space. Now in this Bowman space, no protein is present. So the Bowman's oncotic pressure is usually zero, right? Because no protein can come out of the glomerular capillaries and go here. That is why no protein is present in the Bowman space. But when a patient is having nephrotic syndrome, whenever the patient is having diabetic nephropathy, minimal changes these, then the proteins are gonna leak here, and the Bowman space oncotic pressure is gonna increase, right? Now, this is the first thing. In the same way, tubular oncotic pressure is going to increase in the same way. The second thing is glomerular filtration, right? The glomerular filtration is going to decrease in case of ureteric constriction, and we have already seen how is this thing going to decrease, right? Now, the third thing is intraglomerular capillary hydrostatic pressure, right? So, what are the factors that affect this intraglomerular capillary hydrostatic pressure? We have gone into the details of all of these things, right? We have gone into the details of what things are going to increase the glomerular filtration pressure, what things are going to decrease the glomerular filtration pressure, right? And how is this thing going to happen? Okay. Now, one more questions. Okay. Now, one more thing that I have to tell you, right? So, renal plasma flow, right? So let's touch this thing briefly, right? Let's go over the renal plasma flow once, right? So if you see the renal plasma flow, right? How do we check what is the renal plasma flow? So basically, there is one thing which is known as the renal blood flow. So renal blood flow means that the amount of blood that is coming into the right. So the type of thing that so renal blood flow means the amount of blood that is coming into the kidney, that is known as the renal blood flow, right? And if you only check the amount of plasma that is coming, if you remove all of the blood cells, then that thing is gonna be known as the renal plasma flow, right? Now, uh, we have a thing. How can we check the renal plasma flow? What is the renal plasma flow level? So in order to check the renal plasma flow levels, we can just check one thing, which is the hippuric acid, right? So we check a thing which is known as the hippuric acid, right? And we check its clearance, right? So the amount of clearance that is present, this is the formula for renal plasma flow, and this is important because they can give it for to you to calculate the glomerular filtration rate, right? So you're gonna see the UPAH, right? So the paramyopic acid that is present in the urine, right? And we are gonna basically this is gonna be the renal plasma flow, right? And now we have another way to calculate the renal blood flow as well, right? Now I'm gonna go do a question on this thing as the end, right? Because this is gonna be confusing, right? We'll do a question on it at the end, right? And then we'll go into the details of this, right? We can skip, and I'll pull up a question on this, and then we'll go. Now we are leaving, coming on to that. So the things that we did previously were not as important, right? Now we are gonna do some of the most important things. Right? Now we are gonna do some of the most important things of the nephron, right? And this is known as the nephron transport physiology, right? We are going to start the nephron transport physiology, and this physiology is one of the most important things, right? Right. So we have we need to understand some parts of the nephron, right? What are the different parts of nephron? We have first of all need to understand the proximal convoluted tubule, right? Then we have to look at the thick ascending loop of Henle, which is known as the TAL. Then we have to look at the distal convoluted tubule, and the last part is the collecting tubule, right? So if you understand all of these parts, the nephron is going to be very easy for you, right? The proximal convoluted tubule, the thick ascending loop of Henle, right? The distal convoluted tubule and the collecting tubules, right? We have thin ascending loop of Henle as well. but that does not play a very important role. Right? These are the things that are going to play a very important role in case of nephron transport physiology, and in almost all of our drugs of the body regarding to kidney and diabetes, and some of the diabetic drugs as well, and some of the cardiology drugs as well are going to act on these parts, right? So let's start first from the proximal convoluted tubule, right? First of all, proximal convoluted tubule, the first thing that you need to remember about the proximal convoluted tubule is that it's going to absorb two things completely. What are those two things? Two things are amino acids and glucose. Right? So all of the amino acids and glucose is going to be absorbed here. Right? All of the amino acids and glucose are going to be absorbed here, right? And here we have the famous transporter, which is known as the SGLT2 transporter, right? So SGLT2 inhibitors are going to work here as well, and then they are going to cause glucose secretion in the urine, right? SGLT2 inhibitors are going to work here, and they're going to cause glucose excretion in the urine. Second thing is that these are going to go absorb almost all of the amino acids that are going to be present here, right? Third thing is that there is going to be a transporter here that is going to absorb sodium along with bicarbonate, right? So it's going to absorb sodium, and so it's going to help us to absorb sodium. So it's going to be sodium bicarbonate transporter, right? Why is this thing important? This thing is important because this is how carbonic anhydrase inhibitors are going to work, right? So now we'll go into the detail of carbonic anhydrase inhibitors here, right? So a lot of pharmacology is going to be cleared here on or already in this section, right? So almost all of the pharmacology is going to get cleared here. So we have a thing which is known as the carbonic anhydrase inhibitors. Basically, when we look at the proximal convoluted tubule, right? Here we are gonna have CO2 and water, right? That CO2 and water are gonna form HCO2, H2CO3, and that is gonna form H positive and bicarbonate ion. Right? So we are gonna get H positive ion and we are gonna get bicarbonate ion. So this is the first important thing that you're gonna see. Right? You're gonna see H positive ion and bicarbonate ion, and all of this is gonna happen due to the help of carbonic anhydrase enzyme. Right? Carbonic anhydrase enzyme is gonna lead to all of those things. Right? Now, why is this thing important? Because in the proximal convoluted tubule, now the thing that is gonna come is the angiotensin. Right? So angiotensin is gonna come here. Right? And angiotensin is gonna cause, right? So angiotensin is gonna come here, and then sodium is gonna be present outside here. So this is the blood, right? Right. So basically, this is the urine side, right? This is the urine side, and here sodium is gonna be present, right? So almost all of the filtered sodium is gonna be present here. And the sodium is gonna say, please, I need to get reabsorbed back, right? And remember one thing, right? Whenever you are seeing nephrons, whenever you are seeing kidneys, completely consider one thing is that the sodium's biggest saver is angiotensin, right? Whenever sodium is in any problem, the angiotensin is gonna come. Whenever you see sodium and whenever you look for absorption, the first thing that is gonna come there to help save sodium is gonna be angiotensin, right? So now angiotensin is gonna come here, right? It's gonna cause the sodium to get absorbed, right? It's gonna cause the sodium to go back in, right? And when the sodium is gonna go back in, so if a positive thing is going into the cell, we need a positive thing coming out of the cell as well. This is the basic electrophysiology of the body, right? If a positive thing is coming, so proximal convoluted tubule is a cell. Right. And if in that cell the sodium is gonna come in, right? Something has to go out as well. So the positive H positives have to go out. Right. The only thing that is positive here is the H positive. So the H positive needs to go out. So what is gonna happen is the H positive is gonna go out in the urine. Right? So the sodium is gonna get saved by this carbonic anhydrase enzyme. The sodium again is going to get saved by this carbonic anhydrase enzyme. So this is going to lead to less amount of urine, right? And the second thing is that since almost all of the H positive are going to get secreted into the urine here, right? Since almost all of the H positive are going to get secreted in the urine here, there is gonna be metabolic alkalosis in the body. Why? Because there is gonna be loss of acid. There is gonna be loss of acids and there is gonna be metabolic alkalosis in the body. So this is what angiotensin does. Angiotensin or aldosterone. If you remember earlier, right? When we were studying the when we were studying the Cone syndrome, right? Whenever we are studying that, whenever the aldosterone increased a lot, right? I already told you that whenever aldosterone increases a lot, you are gonna get hypernatremia, right? And you are gonna get metabolic alkalosis, right? Now, if someone asks you, how is this thing possible, right? How is this how is sodium loss? So, what if a patient is having sodium loss, right? If a patient is having increased amount of aldosterone, why is this thing gonna cause hypernatremia, and why is that thing gonna cause metabolic alkalosis, especially metabolic alkalosis, right? So, this is one way, right, in which increased amount of aldosterone or angiotensin can lead to metabolic alkalosis because almost all of the H positive lines are going to be reabsorbed in case for sodium, right? Now we have an enzyme which is known as the carbonic anhydrase, and carbonic anhydrase makes all of these things possible. Now we can give an inhibitor which is known as the acetazolamide. So what is acetazolamide going to do? It's going to block these things. It's going to block the formation of H positive and HCO3, right? Now the formation of H positive and HCO3 are not going to occur. And when this thing is not going to occur, what is going to happen is that the sodium is going to get secreted in the urine, right? The sodium is going to get secreted in the urine. The H positives are going to increase as well. So you're going to get acidosis. You're going to get metabolic acidosis, and you're going to get increased amount of sodium in the urine, and there is going to be diuresis as well. That is sodium. This is known as that the carbonic anhydrase is known as a diuretic, right? That is why it's known as a diuretic. Now, second thing that is important here is that almost all of the absorption that occurs at the point of proximal convoluted tubule is isotonic, right? So here the absorption will be isotonic, right? So increased amounts of in equal amounts of water is going to get absorbed with equal amount of solutes, right? The water level won't be increased as compared to the solutes, right? Second thing is that here NH3 is going to be secreted as well. Right, that is not important. The next thing that is important is that there is going to be another transporter here, which is known as the PTH transporter, right? What is that transporter going to do? That transporter is going to cause, so that transporter is going to absorb sodium and it's going to absorb the phosphate as well, right? Because I have already told you that if one positive thing comes, another positive thing must go out at the same time, right? Or if one positive thing comes, one negative thing must come with it, right? So here, sodium is coming along with phosphate. This is known as the sodium phosphate co-transporter, right? This is known as the sodium phosphate co-transporter. And why is this transporter important? This transporter absorbs almost all of the phosphate back into the body, right? Now, what was the hormone that thrashed phosphate? That was the PTH, parathyroid hormone, right? So parathyroid hormone is going to act here, right? And the parathyroid hormone is going to act here and it's going to block the absorption of sodium and phosphate, right? So it's going to block the absorption of phosphate and almost all of the phosphate is going to get excreted into the urine, right? Almost all of the phosphate is going to get excreted into the urine, and that is why we are going to have a phosphate deficiency whenever we are having hyperparathyroidism, right? Whenever you are having hyperparathyroidism, this is going to happen, right? And here angiotensin 2 receptors are going to be activated as well, and that is going to cause increased amount of sodium and hydrogen exchange, right? That is going to cause increased amount of sodium and hydrogen exchange. So these are all of the things that are occurring here at the point of proximal convoluted tubule. If I repeat to you, the first thing is that there is going to be glucose absorption and SGLT2 inhibitors that can block that, right? Second thing is that there is going to be HCO3 reabsorption here, right? And how does the HCO3 reabsorption occurs all through the pathway of carbonic anhydrases, right? And we can block the carbonic anhydrase path. Third thing is that here sodium and hydrogen exchange is going to occur, right? And again, that exchange can be increased with the help of angiotensin, right? Fourth thing is that amino acids are going to be absorbed here. Fifth thing is that phosphate is gonna be absorbed here, which can be blocked with the help of parathyroid hormone, right? So these are almost all of the things that are gonna occur here. Any questions till now? Okay. Now we have the thin descending loop. So if you look at the nephron, this was a proximal convoluted tubule, and this thin part was known as a thin descending loop. Now, why is the thin descending loop important? This thin descending loop is important because only one thing can be reabsorbed back into the blood, right? Only one thing can be reabsorbed back into the blood from here. From these tubules, only one thing can be reabsorbed back into the blood, and that thing is known as the water, right? So only water gets absorbed back here, right? And when only water gets absorbed back here, what is going to happen is that the urine is going to get concentrated, right? So if a lot of almost all of the solute is coming here, right? If all of the solute is coming here, right, along with everything, right? So the what is the body gonna do? The body is gonna absorb only water from here, right? Only water is gonna get absorbed, and then the urine is gonna get hypertonic, right? So this area is known as the concentrating segment, right? This area is known as the concentrating segment, and the urine is gonna get concentrating, right? It's impermeable to sodium, right? So if they ask you what is the concentrating segment of the nephron, so the concentration segment of the nephron is gonna be the thin descending loop of Henle, right? Now, before doing the thick ascending loop, let's move on to the distal convoluted tubule. Right? So, in case of distal convoluted tubule, two important things are going to be present here. And first thing here I've already told is that there is going to be sodium chloride co-transporter that is going to be present here. It's gonna so if this is the urine, right? It's gonna absorb sodium back into the cell along with chloride, right? Because I have told you when one positive thing comes, one negative thing must come with it into the cell, or if one positive thing comes into the cell, then one positive thing may go out of the cell. So you have to do any of these things, right? So sodium and chloride are going to be co-transported with the help of this co-transporter, right? And the sodium is going to be saved from the urine, right? Now we have a thing that connect here, which is known as a thiazide diuretics, right? Thiazide diuretics are very important. We are going to go into the details of them in pharmacology as well. But thiazide diuretics are going to act here. They are going to they are going to block this thing, right? They are going to block the absorption of sodium and chloride here. They are going to block the absorption of sodium and chloride here at the sodium chloride co-transporter, right? So if this gets blocked, almost all of the sodium and chloride are going to go into the urine at this point, right? And then there is going to be diuresis. Now, this one more important thing that is present here at the distal convoluted tubule is the fact that at the distal convoluted tubule, water cannot be reabsorbed, right? Just like at the thin ascending loop, no water, only water could be absorbed. Here, no water is gonna get absorbed. So normally, almost all of the sodium is gonna get absorbed back, right? But no water is gonna get absorbed. So almost the urine, it's gonna make the urine diluted, right? So the urine is gonna get diluted at this distal convoluted tubule, especially the early distal convoluted tubule is gonna cause the urine to get diluted because the water is not gonna get absorbed here. Now again here the parathyroid hormone is going to act. And how is this parathyroid hormone going to act? Now we have a transporter which is known as a sodium calcium co-transporter, anti-transporter, right? What is this thing going to do? Exchanger. When it's going to absorb the calcium, it's going to let the sodium go out, right? And this is again going to be done with the help of PTH. So parathyroid hormone is going to act here. Parathyroid hormone is going to absorb the calcium, right? And it's going to excrete the sodium in return, right? It's going to absorb the calcium and it's going to uh, decrease the sodium, right? Now, let me look at one other thing. Any questions till now, guys? Okay, so is everything clear till now? Yes, let's move forward. So please keep in mind how does the parathyroid hormone levels act, right? And where does the parathyroid hormones act and how does this act? Because this thing is important, right?
Dr. Moz, I have one question.
Yes.
Like in the distal convoluted tubule, is there is increased calcium? If third, in distal convoluted tubule has a diuretics work, so in that case, calcium level is increased.
Uh, so in case of district convoluted tubule, so what is going to happen is that when basically whenever the kidney works right at the glomerulus, all almost all of the things that are gonna be present in the blood are gonna go out, right? So be it be calcium, be it be sodium, be it be the amino acids, be it the phosphate, be it the bicarbonate ion, the hydrogen ion, almost 20% of the things of the blood are gonna go out. That is known as the filtration friction, right? Now these things are, now the body would say that I want these things back, and the only way to get these things back is through reabsorption, right? Now the reabsorption is going to be occurring at different parts, right? So at the proximal convoluted tubule, the main reabsorptions that were occurring were for bicarbonate, for sodium, for chloride, for phosphate, right? For uric acid and for glucose as well, right? Now the calcium can be absorbed there. There are no transporter for the calcium to absorb there, right? So all the calciums are going to go into the urine at this point. So you're going to go into that. So anything that is present in the tubule is used as the urine. So basically, if I make a better diagram, you can see this diagram, right? If this is the if if this is the proximal convoluted tubule, right? And this is the descending loop of Henle, right? And if this is the ascending loop of Henle, and after this, the distal convoluted tubules come, right? So basically, if we focus here, there are going to be tiny cells here, right? There are going to be tiny cells that are going to be present here. Similarly, some cells are going to be present here as well. Some cells are going to be present here as well, right? And this part here, the blood will be present, right? So blood is going to be present on the outside, and urine is going to be present here. Basically, so anything that is present inside the tubules, that is known as the urine, and these are the cells. So basically, we are taking a section of this thing, right? We are seeing this thing here and we are turning it upside down in this way, right? So this is the cell and this is the cell. So if anything that is present in the urine, it's gonna get reabsorbed here, right? So basically, all the calcium is present here. All the calcium is present here in the tubules, right? And if we do not absorb this calcium, now, after this, the ureter is gonna come, and the ureter is gonna lead to the urethra, right? Right. So, what is gonna happen is that all the things are gonna come here, right? And all the calcium is gonna go out. So the only way is that the calcium is gonna go in here, right? Against the sodium, right? So the calcium is gonna say to the cells, these cells are metabolically active, right? And the calcium is gonna say to these bodies, right? Please let me in. And in order to let it in, the sodium has to go out, right? And at the same time, when the sodium has to go out, this thing is gonna be done with the help of PTH, parathyroid hormone. So only if we have the parathyroid hormone, then the calcium is gonna get reabsorbed. Then the calcium is gonna get reabsorbed. As the calcium is not gonna get reabsorbed, it's gonna go lost, get lost in the urine, and the calcium levels in the body are gonna decrease, right? And at the same time, the same thing is happening in case of proximal convoluted tubule, because in case of proximal convoluted tubule, if you do not block the reabsorption, if you do not, if the parathyroid hormone do not have a lot of parathyroid, a lot of phosphate is going to get reabsorbed. So in order to block the phosphate formation, reabsorption, you're going to have to some things to active, right? Is that clear, guys?
Yeah,
Okay. Okay. Any
thank
other
you.
questions? You're welcome.
So there is one more question related these things. So how gonna prevent this like increased calcium kidney stone in hair?
Okay, yes. So that is a very important question, right? That is a very important question, and this is very important, right? So let's go on this thing, right? So basically, remember, right? Whenever we are giving the patient thiazide diuretics, right? Whenever we are two things, right? One is thiazide diuretics, and other furosemide. These two drugs are very important, right? So one is the thiazide diuretics and another are the furosemide. Why are these drugs important? These drugs are important because whenever a patient is having kidney stones, if we give the patient thiazide diuretics, the kidney stones are gonna go away, right? They can prevent kidney stones. They can treat kidney stones. They small kidney stones can be treated, right? And they could be used for the prevention, right? How is this thing gonna happen? Right? How is this thing gonna happen? Right now, there are now basically, let me go into the detail for a second. So first of all, so if we look here at the distal convoluted tubule, right? So if this was the distal convoluted tubule, right? And first of all, this what was the name of this transporter? Can anyone tell me?
Sodium chloride co-transport.
Yes, sir. So this was the sodium chloride co-transporter, right? Now what drug blocks this sodium chloride co-transporter, right?
Thiazide.
Th- So that was thiazide, right? So thiazide diuretics block this thing, right? So thiazide diuretics block these sodium chloride transporters, right? And if this co-transporter is blocked, what is going to increase in the urine? Will the sodium increase in the urine or decrease?
Increase.
Right? So now, so basically, what happens is that normally sodium moves inside. Right? So basically, sodium moves from the tubular fluid into the cell with the help of this thing, right? So we need sodium in the cell as well, right? We need sodium in the cell as well. So the cell wants sodium at all times, right? So we want sodium almost at every time inside the cell. Now, if we have blocked the sodium chloride chloro transporter, the sodium inside the cell is gonna get blocked, right? The sodium inside the cell is gonna get blocked, right? So let's look at right? Now, if so, this was the urine side. Let me make the diagram a bit more clear, right? So this was the urine side. This was the blood side. This was the blood here. At the blood here, we have the sodium and calcium transporter, right? Now, what is gonna happen is that once the sodium is gonna get blocked, right, it's gonna pump calcium out. So now, since sodium cannot come from here, right, we need another way for the sodium to come into the cell. And where does that sodium comes into the cell? It's gonna come from the blood, right? The sodium is going to come from the blood, right? And all the calcium that is going to be present here, it's going to go out, right? And it's going to be happening with the help of sodium calcium antitransporter, antiporter, right? So in order to get sodium, now what the cell does is the cell takes sodium from the blood, right? The cell takes sodium from the blood and the cell pumps all of the calcium out into the blood again, right? The cell. So now why are the kidney stones happening? The kidney stones basically happen because there is a lot of calcium in the urine. And our end goal is to decrease the calcium in the urine, right? The end goal is to decrease the calcium that is present in the urine. So we need to remove all of this calcium. So in order to remove all of this calcium, so remember all the things go against the gradient. If there are increased calcium levels here and there are decreased calcium levels here, the calcium is going to go move into the cell, right? The calcium is going to go move into the cell. So in order to decrease calcium from here, first of all, we block the sodium chloride co-transporter. The sodium inside the cells decrease, right? Now when the sodium inside the cell decrease, right, we loan sodium, we take a loan of sodium, and that loan is going to come from the blood, right? We're going to take a loan from sodium, and this loan is going to come from the blood. And as a result, the blood is going to ask us something, right? The blood always asks for electrical neutrality. The blood says that I have to maintain my ionic charges, right? I have to maintain my balance. So we send calcium out, right? Now when we are going to send the calcium out, what is going to happen is that the calcium levels inside the cell, inside the cells of distal convoluted tubules are going to decrease a lot, right? They are going to decrease a lot. Now there is a transporter, which is a simple transporter. If you look here, this is the calcium transporter, right? This is the calcium transporter, right? Now what is going to happen is that since there is so much gradient, right, a lot of calcium is going to come from here, right? Or now calcium is going to get removed from here and calcium is going to go inside the cell. And again, since the body is going to need more sodium, the body is going to send calcium out back into the blood. The calcium inside the blood is going to increase, right? And it's going to decrease here, right? Inside the distal convoluted tubule and inside the urine, and sodium is going to come in with the help of that, right? When the calcium is being pumped out of the cell into the blood, right, this inside the cells the calcium is going to be decreased, and that calcium, increased calcium, is going to come from the tubular lumen, right? Now these calcium channels are known as the TRPV5 calcium channels. This is something that you guys don't need to know, but just in case. So these are the TRPV5 calcium channels. These are going to get activated when the calcium inside the cells is going to be less. So more calcium is going to get reabsorbed back into the blood, right? Less calcium is going to be excreted into the urine. And the main reason kidney stones happen is due to the fact that a lot of calcium is present inside the urine, not inside the blood, right? Not inside the blood. So if this is the, again, if this is the nephron, right, if this is the nephron, a lot of calcium is going to be present here, right? And this lots of calcium is going to combine with phosphate, it's going to combine with other things, and it's going to form kidney stones. So in order to prevent kidney stones, we give the patient thiazide diuretics that are going to block the sodium chloride co-transporter. Sodium inside the cell is going to be reduced, and in order to get more sodium from the cell, what are we going to do? We are going to get the sodium from blood, and in order to get the sodium from the blood, we have to give something in return. So what do we give? We give blood, we give calcium, right? So the, so what happens is that we are basically exchanging things. We are exchanging things, that we are getting calcium from the blood, from the urine, and we are getting calcium from the urine, and we are supplying all of that calcium back to the blood, right? So we have two friends. One of our friend is, so basically, if this was a nephron, right? So basically, nephron had one friend, right? And that friend's name was Maverick, right? So Nephron had a friend, and that friend's name was Maverick. And Maverick was very awesome. Maverick always provided nephron with sodium, right? Or let's make it clear, the distal convoluted tubule. So distal convoluted tubule needed sodium to stay alive, and Maverick provided almost all of that sodium to the distal convoluted tubule. Now something happened to Maverick, right? So there was a thiazide that came to the Maverick, and that thiazide blocked all of the sodium transport, right? So Maverick was dead. Now you're not getting any more sodium. Now the distal convoluted tubule needs sodium, right? But there is no direct transporter. There is no direct way you can get sodium into the distal convoluted tubule, right? Because only Maverick was so brave that he was able to provide sodium from the urine. And Maverick was also brave that it provided sodium from the urine, right? So now we need some other person, right? So now what is happening? What could happen is that in the blood, so there is a country which is known as the blood country, right? So in the blood country, or in the blood county, there was a person that said, I can provide sodium to you, but in order to give sodium, I need calcium back in the return. Right? Now, what does the distal convoluted tubule does? The distal convoluted tubule says, okay, I can provide you with calcium. But in reality, distal convoluted tubule does not have any calcium. Distal convoluted tubule is the middleman. So what does the distal convoluted tubule does? The distal convoluted tubule asks the urine, right? It asks the urine, right? Can you give me some calcium? Right? Urine has a lot of calcium. Urine says, yes, sure, I can give you calcium, right? But I cannot let you hold it. So distal convoluted tubule says, okay, right? So distal convoluted tubule takes the calcium from the urine, gives the calcium to the blood, right? By acting as a middleman, and the sodium comes inside the distal convoluted tubule. So this is how thiazide diuretics work, right? After that, we have the loop diuretics as well. They are going to do the opposite of this, right? So we are going to discuss all the remaining part of the nephron physiology and all of the disorders and the metabolic acid base balance and the RAS system tomorrow, right? Okay. So take care, guys, and bye bye.